Hello, everyone. Thank you for spending a little time with St. Luke's Children's today. We are here to talk with you about the COVID-19 vaccine when it comes to children who are ages 12 and older. And just in time for summer break, children ages 12 to 15 can now be protected against the coronavirus by getting vaccinated. The FDA granted the Pfizer-BioNTech COVID-19 vaccine an emergency use authorization. This is for that younger age group, which was approved recently by the CDC. And St. Luke's understands that a lot of parents have questions about the COVID-19 vaccine when it comes to kids. So we wanted to provide you with some direct access to two of our St. Luke's Children's experts to answer those questions for you. We have Dr. Kenny Bramwell. He is the St. Luke's Children's System Medical Director and Emergency Physician, and Dr. Alicia Lasciando, an Associate Medical Director for St. Luke's General Pediatrics and a St. Luke's Children's Physician or Pediatrician. Thank you. And if you have questions while we're getting started, go ahead, put those in the YouTube chat feature. We're going to monitor that a little bit and try to get to your questions and answer them just as best we can in order. So please use that chat function and we'll get to your questions as soon as we can. Let's start with some of the very basics about this Pfizer-BioNTech vaccine, its safety, efficacy when it comes to protecting adolescents and adults.
Kenny, do you want to take this one?
Yeah, sure. Thanks, Anita. You know, this is actually, as it's rolled out over the last almost 6 months now, this has been a fantastic development in the 12 to 15-year-olds. In the population of older adults, say ages 18 and above, we know that the data show that this vaccine is about 95% effective at preventing significant illness. And we've been watching this for many months, and then more recently, this changed to include both 15 and 16-year-olds, as well as most recently, last week, 12 to 15-year-olds. What we know is that it's actually better than 95% in these teenagers or preteens down to 12. I have seen statistics where they're rounding off to 100%, where everyone who has gotten the vaccine has shown positive results of preventing additional COVID, as well as they're doing antibody testing on these patients. So if you want to be really strict about it and say it's only 99%, that's still phenomenal level of efficacy for this new vaccine.
Yes, and compared to other vaccines that we routinely give, it is out of the park amazing to be able to offer something that is this effective to our families, and with a risk profile that is lower than so many other things that we offer on a day-to-day in clinic. I would say that the biggest risks, of course, are soreness and a couple of days of fatigue, body aches, fever, but we are not seeing really serious adverse events in children in the vaccine that's been studied in this population for many months now.
Maybe explain for parents just immunity in kids and the immune system. Are they having a stronger reaction or any sort of a different reaction than adults do, just simply by nature of the makeup of our bodies and how well they work as we age?
Sure. So our immune system, the human immune system it's most effective in our preteens and adolescents, I would say. Both in terms of mounting a robust response to any invasive disease, but also in terms of creating memory immunity. And that's why, for instance, our HPV vaccine, we are able to offer less vaccines the younger you get it, because it is much more effective at creating long-lasting memory immunity when you're younger than it is when you're older. And so similarly, we're seeing kids have a robust reaction to this immune reaction to this vaccine, meaning they are getting the body aches, the fever, and the chills. But that's also telling me that it's working. The immune system has recognized the blueprint that we've set to it. It's making antibodies and it's activating T cell immunity. And that's the thing that's really important, because a lot of kids, when they get COVID itself, when they get what we call native COVID, they have a mild reaction to it or no reaction, which means that their body isn't necessarily mounting the same antibody response. So the chance of their immunity waning and getting it again and potentially getting it more severely, depending on the variant, is more likely than with the vaccine. We can say your immunity is going to last a lot longer and be much more effective against variants.
We have Chad who asked, and this is a question that we hear a lot, is it safe? I know you've sort of answered what the studies say, but we hear these false rumors, and I want to say these are false rumors about deaths and reactions connected to the vaccine. So what is the actual scientific data telling us about this vaccine when it comes to the risks and the safety?
You know, we have a number of, that's a great question, Anita. We have a number of ways that we're tracking this. We have the Vaccine Adverse Event Response System, or VAERS, that is helping us track this nationally, and we have data from those sources. We also, within St. Luke's, I keep track of this pretty closely. We've given just over 150,000 vaccines since December 18th, which was our first day. So we're coming up on 6 months here. I guess we're just at 5, maybe 2 days ago. We have had really good indications that the side effect or significant side effect rate is exceptionally low. The place where we've been able to track it the best, I would say, is a subset of the vaccines that we've given to our own employees. So these are not children, these are adults. And we have kept track of any employee who has a significant side effect, and the significant side effect rate is less than 1%. We also keep track of the number of people who, if they're cooperating with us and they sit there for 15 to 30 minutes after they've gotten their vaccine, we've given, I believe, 31 doses of Benadryl in that same period of time and 1 dose of epinephrine. So the number of people who are having sort of immediate severe allergic reactions is very, very low. And that's all comers. That's not just employees. The employees, we have the best insight because we're able to hear, 2 days later, maybe they're one of those unfortunate people who is having ongoing muscle aches or fevers and just really isn't quite able to work. So we are able to document those. And like I said, that's quite low as well. We've just been giving these vaccines for a much shorter period of time to our younger patients, so we don't yet have a great handle on the rates of those significant side effects, but I expect them to be very similar.
I think it's important to note too, I just looked at the numbers this morning. We have close to 80% of our 15,000 employees that have received the vaccine at St. Luke's. So that's saying something about those numbers for the context with that. And sticking with that theme, would those people have had a reaction to some sort of other vaccine? Or is it just something about this particular vaccine that we're finding that a very rare amount of people are having some sort of allergic reaction?
So that allergic reaction number is very much in line or maybe even less than compared to some of our other vaccines. So there are people who are more likely because of autoimmune processes to have a stronger reaction or be more likely to have the need for Benadryl, and would expect that to be with other vaccines. There's nothing particular to this vaccine that raises that risk. And I want to point out that a lot of the concerns about serious or long-term side effects are so much lower with the vaccine than it is with native COVID, even within our kids. That while children are less likely to have serious side effects to COVID or long-term side effects to COVID compared to adults, it's still much, much higher from the native illness than it is to the vaccine. And so I talk a lot about that with my families. I've had multiple patients in their teens who have experienced, in some cases, really debilitating side effects that have kept them from school for long periods because of COVID, or in one case, a second COVID infection. And in that case, actually, they had some improvement once they got the vaccine. But I've had with a lot of joy, I've had quite a few patients, 12 and above, who have already gotten the COVID vaccine. Some of the older teens who have gotten both of their doses, and they've done really well.
Great. We have some questions coming in the chat. We're going to get to those, but I want to stick with this theme too, Dr. Lasciando. Melissa wrote in earlier and asked, I'm considering getting my 12-year-old a vaccine when making parenting decisions, I generally weigh the risk versus the rewards. I'm having a hard time deciding to get her the vaccine when the risks of the vaccine are largely unknown and the risks to her if she gets COVID are very low. Do you have any numbers or anything that would help me in my decision making? I have been looking online for data, but have been struggling to find anything concrete. And I know this is a common theme. Lots of parents searching online to find that data, but they've got you guys who have that data accessible. So what would you say to Melissa?
So what I would say first is this is the perfect way to frame this, because this is exactly how I talk about it with all of my families. Every medical decision I make is risk versus reward, because every intervention, whether it's recommending an allergy medicine or a topical skin cream or discussing, what foods to start, it's all risk and reward. And when we talk about the risks of the vaccine being largely unknown, I think that's actually a little bit false. So what we know about vaccination from a century of data of all vaccination, but really a decade with the mRNA vaccine, and then more specifically, this vaccine has been in development for almost a year. As the COVID pandemic hit, because of the way this mRNA structure to this vaccine was, they were really able to hone in and get started on researching this particular vaccine, Pfizer and Moderna specifically, very quickly and get it into trial. And so when we know that the vast majority of serious adverse events or risks from the vaccine will happen within days to weeks of the vaccine, and now we've got months and months of data, I think we can pretty accurately describe what the risks will be. The other side of that is knowing physiology. The physiology of a 14-year-old and an 18-year-old are really similar. So even though we haven't had as much data in 14-year-olds, we can extrapolate from the 18-year-olds pretty confidently. And I've talked about this with our peds infectious disease doctors at length to make sure that they feel as confident and comfortable with it. And then knowing that the COVID risk is low, yes, but it's still higher. We saw some data recently about the effects of COVID in teenagers being significantly higher than H1N1 back in 2008. Even though we talk about COVID not being as affecting kids, it still was worse than one of the worst flu pandemics we've had in a long time. So the risk is definitely higher with the disease than it is with the vaccine. And the rewards, in my mind, are great. First and foremost, peace of mind, knowing that this is so effective and I don't have to worry about my child being one of the misfortunate or unfortunate kids who get serious effects. What it means for in the future in terms of whether or not through contract tracing at a sports team or at school, your kid is going to have to consider quarantining or miss time because they've been exposed to COVID. If they're vaccinated, what we know is their risk of transmission is much lower. And so it will allow us to keep our kids in school much more consistently and really return to the normal rhythms of our lives that we've been craving and missing so much.
Dr. Bramwell, I want to go ahead. Did you want to add to that?
Yeah, I want to add to that. I think what Alicia said was spot on, certainly as far as individual risk versus benefit thoughts for this mom who's being really cautious. Another way to think about it is sort of being part of the us. The way that I would couch this is the more of us who can get vaccinated, the better it is for all of us. The virus lives in humans, propagates in humans, spreads between humans. The more we can take out people out of the cycle of getting exposed to COVID, developing COVID, spreading COVID, the better we're going to be collectively. So I can certainly understand the idea that we want to focus on how risky is this to my child and what are the immediate upsides to my child. I'd just like to add for this mom to consider, that if you've got a young, healthy child and they're able to get this vaccine and it's convenient and everything else lines up, the best thing we can all do is try and get these folks vaccinated. I felt strongly enough about this. As you know, Anita, I was there on the first day, fortunate enough to get vaccinated because of my work in the emergency department. But since then, I've had everyone else, as their age or medical conditions have been able, we've gotten them vaccinated. Fortunately, that now means that all of my younger kids are vaccinated. Sorry, my older teenage kids are now all vaccinated. But the message I'm trying to convey is this will help get all of us back to a more familiar state. The more of us that we can get vaccinated.
Yeah. And I also, the last thing to point out is, as we see, worldwide variants are popping up and spreading, there are more variants. The variants that will be potentially more prevalent this summer seem to have stronger reactions in our adolescents than prior variants. And so I would love to be able to protect kids as much as possible from any of those short-term and long-term side effects.
Absolutely. We've had some conversation in the chat on the YouTube channel. And one of the questions is about, I can never say this word, is it tinnitus? And tinnitus, thank you.
It depends on who you ask. If it's tinnitus or tinnitus, everyone says it a little bit differently.
Well, people are wondering about this. We keep hearing about people getting the vaccine and a small percentage of people having some hearing loss from it. It seems to be more associated with the Johnson & Johnson vaccine, which is not eligible for children at this point. Only the Pfizer vaccine is eligible for people 12 and up. So what do we know about that risk of a hearing loss, or is that a concern in children at all, or have we seen any data even out of the studies that talk about that with children?
So the way I would approach any data or reports that are coming out of this, especially as they're reported to VAERS, is a couple of things. One, what we do know about tinnitus and tinnitus with live or native COVID vaccine, you're going to see higher numbers than that. Two, than what you see with the vaccine itself. Two, there is correlation and there's causation. And so one of the things as we unpack this data and these numbers is, was this tinnitus or hearing loss caused by the vaccine? Did it happen to coincide with the vaccine, or was it pre-existing to the vaccine? And so when I see a report of less than 1%, when all of those things are included in a report and it's less than 1% of people experiencing this at all, then I feel really great about it. I think about all of those medication ads that we see, and they give you the long arm's length list of possible side effects may include. And as I weed through those when I'm prescribing any medication, tinnitus pops up usually somewhere between 1% and 3%, and it could be for an antibiotic, it could be for an ADHD medication, it could be for an allergy medication. I have to remember that that is not true causation numbers. That is somebody reported that they had this symptom around the time that they were taking this medication or receiving this vaccine. And so I think that's a really important way to look at that. So when I see a number of 0.71% reported any tinnitus around getting this vaccine, again, compared to medications that I use on a daily basis, I actually feel really good about that in my pediatric patients. And again, we're talking about at this point, 12 to 18. I'm not talking about at this moment giving this vaccine to a 6-month-old or giving this vaccine to a 5-year-old. I'm talking about 12 and above, whose physiology is very similar to, in reaction to vaccine is very similar to what we would expect in the 18 to 29 population.
Speaking of those younger kids, so many parents are wondering when that age group could potentially be vaccinated. We're hearing fall. What's going on in terms of clinical studies and trials for kids younger than 12?
So what I can add, Anita, is my understanding is that Pfizer has divided the younger kids into these groups. We've got a 6-month to 2 years old group. We've got a 2 to 5-year-old group and a 5 to 11-year-old group. We already have been talking about the 12 to 15 as another group and the 16 and 17-year-olds as those other groups. So they've got them divided now into these 5 groups that doesn't go down below 6 months. It's possible that there could be a 6th group there, but that's my understanding is the way that they have divided it out. I've heard or read, I should say, a few things about Pfizer hinting that September is when they're going to be asking for additional EUA consideration for one or two of these additional groups. I haven't seen that any firmer than that, but I did see that in a few different articles in the last week or two.
And I will say that there are ongoing studies, I believe, for not just Johnson & Johnson, Pfizer, Moderna, also Novavax, and then, of course, our colleagues across the pond, AstraZeneca, in all of these age groups. Personally, my 12-year-old nephew has participated in the Moderna vaccine trial and has done great with it. And it has made himself and his mother much more comfortable with his participation in sports of late. But also, my 9-year-old nephew is waiting for his turn in that same Moderna study, and that should be happening this summer. Moderna doesn't, as a smaller company, does not have quite the machinery or the robust ability to operationalize this as quick as Pfizer, which is why we're seeing Pfizer take the lead here. Not because of any holdback based on safety concerns. It's actually just making sure that they get the studies done correctly with the right number of people and are tracking it correctly. And that takes a lot of effort and time. So yeah, and I think if you look at how those are broken up, I just want to add to Kenny, again, talking to my peds infectious disease colleagues, those have to do more with who is at risk for the disease and less on the risk of the vaccine to the child. Because again, even though we talk about this being quote unquote new technology with the mRNA, it's actually what I would consider a less technology than a lot of the vaccines we already have. The components are there, but instead of giving a whole part of a piece of the virus, a larger protein piece of the virus, we're giving a very small blueprint. So there's a lot of enthusiasm and optimism about what this means for us going forward for all diseases. This is what I would call a huge paradigm shift in infectious disease and public health in a global scale with this vaccine. But again, the reason that we're talking about 12 and above and then 5 and above is really school ages and getting kids back to who might be more likely to transmit it than their 3-year-old sibling or their 6-month-old sibling, and getting them back to school, full capacity, not having to have absences without masks, eventually being the goal.
So we are taking questions in the chat. If you have a question, feel free to chime in and we'll get to those questions. Dr. Bramwell, building upon that, I'm curious if you can explain for people the time frame on this vaccine. I hear that a lot, that this happened so fast. How can this be safe? It was done so quickly. But what was happening even prior to COVID-19 related to this vaccine that gives a lot of people in the medical field a lot more confidence in this?
Sure. I'm going to use a sports analogy, and the sports analogy I will use is Olympic swimming, where every 4 years, we all watch Olympic swimming or Olympic gymnastics, and we say, oh my gosh, these people came out of nowhere. I haven't heard anything about Michael Phelps in 4 years, and all of a sudden he's winning all these medals. All of this has been happening for more than a decade. It's just not been on people's radar. People don't read science magazines, and they don't look up protein synthesis journals. But all of a sudden, we're talking about mRNA as a way to give the body instructions for how to make the spike protein of a brand new virus. I will say that a handful of years ago in 2015, when Ebola looked like it was going to become a worldwide pandemic, or certainly become much more of a problem for places outside of the 4 initial countries, this technology was ready to go. They had an mRNA vaccine poised and ready to start infusing into people if this became more of a problem. It turns out that ultimately wasn't necessary, but that was 6 years ago that this vaccine was ready to go. This technology was ready to go. My understanding is that the technology's been ready for about 10 years, and they've just been waiting for the right virus to come along. I'm happy to say that we didn't have a pandemic that needed it before now, but man, it's just phenomenally helpful that this technology was poised and ready. But to many people, it feels like this came out of nowhere. Like they've never heard of mRNA vaccines, they've never heard of this technology. So it can't be that this was ready to go. It must be that this was rushed somehow.
Yeah.
And I want to just reassure people that it wasn't rushed. It just happens to have been ready. You know, the fact that these companies were able to sort of exercise their financial power and get things moving unbelievably quickly is more a testament to the level of urgency that the world felt, more than that safety considerations were skipped or that the evaluation phase was shortchanged somehow. All of this stuff, this has been the most closely studied vaccine in the last 100 years, and it didn't come out of nowhere. It just wasn't on people's radar.
And that exactly, I would say, as somebody who talks about vaccines pre-pandemic a lot and nerds out and finds as many long-form articles from different sources as I can on vaccines and vaccine development. The maybe the unfortunate part is when it's not urgent or when there's not a pressing need, the funding isn't there. And there are scientists who have been spending their life trying to make sure that we are ready and for the next and make these better, safer, more efficient, with less side effects continually. And that's where this mRNA model, you know, the other thing that has really made this possible is our ability to very quickly genome sequence. That wasn't a possibility 15 years ago. So you can more quickly figure out what your target is and get to work developing for it if you have the financial power and the manpower devoted to it. So that is where I say this is so exciting looking forward. And also to go to the emergency use authorization versus full, which I know Pfizer has already applied for full, and I expect to be granted. Looking at the emergency use evaluation was not a quick or hasty decision. And actually even more so in the United States than anywhere else. Whereas the EU and Great Britain took the data that they had from AstraZeneca or Johnson & Johnson and looked over that. The FDA actually asked for every single data point. They didn't look at the already packaged data. They looked at every single data point and wanted to reanalyze all of it themselves to make sure that with these vaccines, and specifically as we're talking about Pfizer as it relates to kids, that they agreed with the conclusions in terms of safety and efficacy, and that the methods were done correctly. The skip from EUA to full authorization has more to do with figuring out recommendations for how often we're going to give this vaccine, to what ages, how it works in with our other vaccine platforms. It's not that it wasn't looked at or studied or reevaluated at all. And again, they had months of data to evaluate before giving the EUA.
You know, sometimes I think when these things are complex, right, and we're lay people who don't understand the science of it, it is a little bit unnerving maybe to think about it. So for people who don't understand exactly what mRNA is, parents wondering what that's doing to their child's DNA, we hear that concern a lot, that it's changing your DNA. We know that's not the case. So explain for them how this then works on the body.
Sure. So mRNA is not DNA. We all have mRNA in our body, and every single cell. It is it's messenger RNA. It is the messages that are sent out from our DNA to the working elements of our cells as to what proteins to construct and how to construct them, and what needs to be done. It's not this mRNA at no point does it embed within our DNA. And so the way specifically this works is they found a way to get, instead of, again, having to show, thinking of it as instead of having to show the weapon and show the person and the threat to the cell and say, fight this, and then remember how you fought it and tell everyone else how to fight it. They're giving the blueprint to the cell. They're saying, we think that this is going to be the thing that cells are going to use to attack you. Make a few of them, tell your cells how to fight it, and then remember it. And so there's no way that this mRNA can become a virus. It doesn't contain all the information for the COVID virus. It contains a very small portion of a small protein to it. It doesn't embed in our DNA. That mRNA just gets taken up by our normal machinery, our ribosomes. They make a few of these proteins. The cells say, okay, we're going to attack this. And now how do we remember how to attack it?
Another thing to add or to think about is mRNA is a temporary blueprint that gets broken down on its own, and the body breaks it down by normal processes. So the mRNA that we are injecting into our shoulders has a number of hours that it's viable. And the other thing to think about is that's part of the reason with the Pfizer vaccine that things are so complicated. This mRNA will break down outside of the body if it's not kept at low temperatures. So it's packaged in a very specific way. It has to remain in these freakishly low temperatures for transport, and then has to stay in these low temperatures until the day that it's given, and then it can be given. And so part of the reason for all of that extra work with super cool or super low refrigerator temperatures is that this material of the vaccine will break down on its own when exposed to warm temperatures for too long. So there's only a certain period of time that the vaccine is at the right temperature. And that's why I say at the end of the day, you have vaccine that you haven't given, you can't give it. It can't be refrozen and give it another shot. Once it's thawed, it has a short period of time it can be used. So just something to add on to what Alicia already said.
Well, and expanding on this, we hear rumors about parents being concerned that there could be some sort of impact on reproductive health. This was something we heard about when they were discussing pregnancy and the COVID-19 vaccine, which was ruled safe to do. So where did that rumor come from? And I guess maybe better explain how it's not the case, kind of based on what we know on the technology.
Yeah, so there's two parts to this. The pregnancy one I want to address very, very bluntly. Pregnancy and breastfeeding, the reason it was not initially done is traditionally, when doing studies on any medication or any vaccine, they initially roll it out to non-pregnant, non-breastfeeding folks first, just to make sure that it's safe in that group first and not pregnant and then pregnant and breastfeeding. So that's a historical standard. It had nothing to do, there was no concerns from this, any component of this vaccine that they thought would be more likely to cause any harm. And it's actually kind of an outdated and antiquated thing that a lot of my OB-GYN colleagues and infectious disease colleagues are trying to push against, because there is no really good biologic reason that it could not have been tested in those folks initially. And so as they completed the tests in that group and said, this is absolutely fine, that rolled out. It wasn't because they were worried specifically that it was going to affect fertility. That's just the nature of how medical trials have gone, period. Second, the fertility question is one that when, again, I deal with kids and parents and I talk to them about things all day, every day, it's always on the forefront of minds for everything. They want to make sure that their child is going to be able to live a long, happy, healthy life and do all the things that they want to do. But interestingly, every single vaccine every time it's been rolled out, this is one of the questions that comes up. And it doesn't come from anything specific to this vaccine. I know there was some report about some ingredient that had a similar name to something else. There's nothing in this that is going to that puts you at any higher risk for reproduction and fertility. And so, again, any more so than I would expect when I prescribe an antibiotic or tell you to take ibuprofen that it would have any impact on fertility. And so I feel very confident when I explain that to my families, saying that I have no concerns that this will impact long-term fertility, just like any of those other things.
Dr. Bramwell, I know we've been talking a lot about the vaccine, but I think it's really important to put the focus on why we even have this vaccine, which is the COVID-19 virus. You work in the hospital. We've had children in our hospital with this. From your perspective, looking at the risk for kids with this virus, what did you experience in the hospital related to this, or hear about from our physicians that make you just really strongly tell parents that this vaccine is so much better than getting the virus?
Sure. Thanks, Anita. Yeah, I've been doing a rather manual process for the last year that we've been admitting kids to the hospital with COVID. And I'll tell you what that is. Each week, usually on Monday, sometimes I forget, I will send an email to my partners who are the medical directors for our pediatric hospitalist group, our pediatric intensive care unit, our neonatal intensive care unit, as well as our pediatric surgery and pediatric St. Luke's Cancer Institute leaders. And I asked them, did you have any patients admitted to our hospital last week with COVID? And if so, could you get me the patient's name and what we call the mRNA or medical record number? And then I look at each of those charts and try and figure out, why did this patient need to be admitted? I'm not being critical. I'm just trying to understand. You know, was this a totally healthy child who happens to have gotten COVID? Was this a complicated child who happens to have gotten COVID? Or in some cases, was this a surprise COVID where they were being admitted for something else, appendicitis, let's say, and before they went to the OR, we did a COVID test to sort of guide how we would manage the patient in the operating room, and surprised, they had COVID. So we've had patients in all of those categories. We've had about 75 patients in the last year who have needed to be admitted to the hospital for COVID. Now, many times they've needed to be admitted to the hospital for something else, and COVID was sort of a bonus or a surprise. I would put the people who have needed to be admitted into a couple of categories. Our biggest group has been the patients who have complicated medical histories and are on lots of medications and have maybe chromosomal issues or prior heart surgeries as a 2-year-old, where they have needed to be admitted to the hospital for COVID because they are somewhat frail medically normally, and then they get COVID and they just are much sicker. The next group of kids I would describe as incidental findings of COVID. They had a bad head injury and they were COVID positive, and they have nothing to do with each other. They had appendicitis, and this wasn't from COVID, but did change the way we managed PPE for them. And that was a relatively large group. I would also include in that group patients who needed to be admitted to the hospital for a psychiatric crisis who ended up having COVID and largely did not have symptoms of COVID. And then the final two groups would be our MISC, which is the multi-system inflammatory syndrome for children. And we've had just about 15 of those kids in the last year who have needed to be admitted because they have typically been otherwise healthy, and then 3 to 4 weeks after having acute COVID, they develop these side effects of blood pressure problems being low, dehydration, abdominal pain, rash, high fevers, and similarly. And then the smallest group that we have had within our children's admissions to the hospital have been kids who have had what I'm going to call acute respiratory COVID, where they get COVID from some source. 3 days later, they're coughing, sneezing, wheezing, having shortness of breath, and they need to be admitted because they're having trouble with their oxygen needs. And we've had, I believe, 2 or 3 of those cases in the last year. So it's somewhat different than what we're seeing in adults, where there's far more acute respiratory COVID that happens and requires patients to be admitted than has been happening in children.
And Dr. Lasciando, expanding on that, you touched on it briefly again, but I think we always put it in this, we measure COVID seriousness based on deaths and hospitalizations. And that's not the outcome for everyone. From your experience, even with teenagers, again, talk a little bit about what some of those side effects are that concern you, with people just saying, hey, I'll just let my kid get COVID on his own or her own, rather than get the vaccine.
Yeah, and I really appreciate that call out, because there's not only two outcomes in medicine, and there's not only three outcomes in medicine. And the vast, again, in pediatrics, I'm lucky that most of my patients are happy, healthy, get better from anything. And I, go on to live happy, productive lives. And I transition them on to my adult medicine colleagues. And I don't have to worry about death in the same way. But with COVID, like many other illnesses, but more specifically than a lot of viruses that we see, flu, RSV, colds, I've seen a lot of kids with very variable symptoms. I've had kids develop long-standing GI symptoms where they lost a lot of weight because they have ongoing diarrhea and abdominal cramping after having COVID. I've had patients with really bad problems with what we call POTS, so postural orthostatic tachycardia syndrome, where very healthy, and these are, I want to point out that these kids that I'm talking about are healthy, active teens. I can think of teenagers who it's really limited their ability to participate in sports, not because they've had serious cardiac side effects in what we think of like the myocarditis or heart failure, but they're getting incredibly lightheaded. Their exercise tolerance is low, and it's taken months for them to get back to where they want to be. And if I can prevent any of that for my patients, especially with a safe, effective intervention, I am more than happy to do it and recommend it.
All right, last question, unless there's any that are going to come in the chat here at the last minute. We keep seeing all these TikTok videos of people sticking the magnets on their arms saying it's because of the vaccine. What is that?
I think that's a lot of people who are trying to get likes and views and circulation. It's pretty easy to put a sticky pad on the back of a magnet and stick it to your arm. I am more than willing to have anyone come up and try and stick a magnet anywhere on either of my arms from where I got the vaccine, or anybody else who is vaccinated. And I will guarantee you that unless there is an adhesive on it, that magnet will not stick.
Anita, I wanted to add something.
Yeah.
One of the sad realities we've had within the Children's Hospital is there's been an uptick both of non-accidental trauma or child abuse, and there's been an even larger uptick in the number of kids who've needed to be admitted to the hospital for behavioral health crises. Sometimes those are anxiety, sometimes those are depression, sometimes those are suicidal gestures or attempts. The reason that most of these kids have struggled so mightily is because of all of the sort of pandemic-based restrictions that we've had. And while I am certainly supportive of the restrictions that we've had, I want us to all do as much as we can as a group to get us out of this phase of restrictions. And the vaccines, to me, are the way out. The vaccines, if we back up and start thinking about the beginning of last year, our initial problem was, oh, good heavens, we don't have enough PPE. Then the next thing is we don't have a way to protect people in the community and in the hospital. And then, oh my gosh, we're going to run out of hospital beds. We've had all of those different phases. To a large degree, to me, all of the stuff that we did the first 10 months was waiting until we had a solution for COVID. The vaccine is that solution. We now have the way that we can move forward by getting the vaccine into as many arms as quickly as possible, so that we can sort of emerge out the other side and start lessening some of the vaccines, so that we all start seeing people's faces again and seeing people in person again, and modify schools as best we can.
Yeah. And I think it's important to remember that if any feelings that we have that the pandemic is near over here is because we've been lucky to have that vaccine. If you look worldwide where the vaccine is less readily available, those fears of overwhelming hospitalization, increasing death rates, long-term side effects, school shutdowns, sporting events shutdowns, all of those go hand in hand with them not having the access to vaccines that we do here. And so to piggyback off of that, that feeling that we have that it's almost over goes hand in hand with our ability to get vaccinated.
Well, thank you both so much for sharing your lunch hour with us and answering all of these questions for parents. We have a recording of this that we're going to share on our St. Luke's social media pages. If you want to share it with friends and family who have questions, we'd be grateful for that. Our goal is to just really get good, solid, factual information in the arms of people who need to make decisions about whether or not to vaccinate their kids. So we appreciate you taking time to learn with us. And if you have more questions, you can check out the St. Luke's COVID-19 vaccine webpage. That's at stlukesonline.org. Thanks so much.